Can you first just summarize or give us a take-home messages from your morning's presentation?
Well, I guess there's several messages. The first is that the metabolic syndrome is very common. It's increasingly prevalent. It increases with age. The older you are, the more likely you are to have the metabolic syndrome. It is undoubtedly a predictor of the development of both diabetes and cardiovascular disease, but in fact it's a much stronger predictor of the development of diabetes than it is of cardiovascular disease. And then I talked a little bit about whether it is as good a predictor or maybe even a better predictor than other risk prediction tools. And most of the data that's looked at that would tend to indicate that it's probably not quite as good as specific tools for predicting cardiovascular disease or than specific tools for predicting diabetes. And the other area that remains one of concern is trying to define waist circumference, cut points, in a similar fashion around the world. We certainly know that we need different cut points in different ethnicities, but the way that the definitions have been approached have been very different in different parts of the world, which makes it very difficult to make any comparisons.
It's quite interesting that you mentioned ethnic differences and population differences. How do you think that affects clinicians and the way they practice today, with regards to metabolic syndrome, diabetes, and hypertension?
Well, I think that the key thing here really in terms of ethnic difference is in relation to the waist circumference, or more broadly in relation to trying to assess obesity. We know, for example, and it specifically applies to Southeast Asian and South Asian populations, that we see conditions like diabetes and other obesity-related conditions emerging at much lower BMIs or waist circumferences than we see in European populations. And we need to account for that somehow in order to give practical advice to clinicians about what is a level of adiposity at which they should be doing something with their patients, whether it's giving them advice, whether it's giving them treatment, but at a level that signals a problem. And so we need to try and come up with useful values that are just as useful amongst the South Indian population as they are amongst a Northern Scandinavian population. We need different numbers, but we need to know that we're talking the same language.
Any tip from today's conference that you've heard of? You've heard various presentations. Anything that really stood out? And if there's one particular tip that you would give clinicians that they could bring home to their practice, what would that be?
Probably a couple of things. We heard some really interesting information this morning on salt, on the relationship of salt intake to hypertension in particular. I don't think there was anything new in that relationship, but it was a really important thing to hear, that the relationship between salt and blood pressure, because I think as clinicians we often forget that advising our patients to cut down on salt would be advisable. I think the other interesting thing from that presentation was the suggestion of the link between the high salt food and the influence that has on buying lots of soft drinks. Unfortunately, it's the same company, so there is an interest, it would seem, in increasing the salt content of food so that they can sell more of their drinks. On a more scientific level, I think one of the other interesting things is the increasing recognition that we have that fat is different in different parts of the body. We now, I think, all recognise the importance in general of visceral fat as opposed to subcutaneous fat, but we were hearing today also about mesenteric fat and whether that may itself be an important fat depot. And I think we're learning more and more about those things. I'm not sure yet that those translate into practical clinical practice points.